Good morning. Thank you for your assistance. At this roundtable, we are going to talk about clinical cases. The first presenter is Dr. Marco Davi Gomes de Sousa, who will present the case exotic Mycobacteria in a patient with HIV immunosuppression. Dr. David, you have 20 minutes.
Thank you. Good morning. My name is Marcos Davi, and I work at National Institute of Infectology. And the title of our work is Exotic Mycobacteria in a Patient with HIV Immunosuppression. And our team is composed by Gabriela Robledo, Karen Gomes, Maria Cristina Lourenço, for me, and Dr. Cristiane Lamas. Non-tuberculous mycobacteria, NTM, are generally free-living organisms that are ubiquitous in environment. NTM infection is from environmental sources, as natural water, drink water, household plumbing, and soils. And human infections occur by inhaling dusts from soil and aerosol from water. As diseases of non-tuberculous mycobacteria, we have pulmonary infection, sinusitis and otitis media, nosocomial infections associated with surgical interventions, cervical lymphadenitis in young children, and bacteremia in individuals immunocompromised. The gold standard for detection of NTM infections is culture. So rapidly growing mycobacteria form colonies by 3 days on agar-based complex media. And slowly growing species require 7 to 10 days on agar-based complex media. An alternative to culture is PCR-based amplification of genus or species-specific sequences as 16S RNA, ribosomal RNA internal transcribed sequence, ITS, HSP65, and RPOB gene. So let's go to the case report. Our patient was a 51-year-old male. He was COPD, and he was heavy drinker and smoker. He was two-way speaker, HIV positive and poorly adherent to antiretroviral therapy. His CD4 count was 14, and HIV viral load was more than 3,000. Here we have the patient's CD4 counts, and we can observe very low CD4 levels and a persistent viral load in this patient. As past treatments, in 2007, the patient was treated for TB for 3 months with rifampicin, isoniazid, and pyrazinamide. But Mycobacterium tuberculosis wasn't confirmed. From 2007 to 2009, Mycobacterium kansasii was detected in the sputum, and the patient was treated with rifampicin, isoniazid, and ethambutol. In 2009, the end to 2009, Mycobacterium avium was detected in sputum culture, and ciprofloxacin was associated to the treatment. At physical examination, the patient was in regular general condition, cooperative on the exam. He was malnourished, 97 pounds, BMI 17. He was pale and there was no cyanosis or jaundice. No palpable lymph node enlargements, extensive oral candidiasis, cardiac auscultation was normal. At pulmonary auscultation, breath sounds globally decreased and crackling, abdomen normal. In skin, extensive lesion in a very periodic dorsal region, small scarification and lichenification wounds was observed. Here we are. Here we have the chest CT of the patient when we can observe diffuse and bilateral areas of panlobular emphysema, excavation of the thin and irregular walls located in the topography of the right oblique fissure with no interior content. Bronchiectasis surrounding this lesion can be observed too. As previously stated, he was treated for Mycobacterium kinseyi infection from 2007 to 2009, when antiretroviral therapy was also started. In 2015, several sputa were collected and observed that there were AFB testing positive, but we performed gene express tests and all samples were negative, leading us to believe that it wasn't Mycobacterium tuberculosis. In January 2015, there was positive culture for Mycobacteria intracellular. In September and November 2015, sputum culture positive for atypical Mycobacteria. And November 2015, positive culture for MAC and bronchoalveolar lavage, later identified as Mycobacterium colombiensis. The clinical specimen was decontaminated using of NOLC sodium hydroxide method and was seeded in low-STI ginseng medium. There was growth of the Mycobacterium colombiensis 30 days later. Sequencing of the RPOB gene for identification showed similarity of 99% with the CIP 108962 strain Mycobacterium colombiensis. The gene sequence was analyzed by BLAST version 2.0. All blood cultures for fungus, Mycobacteria, and bacteria were negative in the same time. Unfortunately, patient didn't return to the medical appointments for several months. In April 2016, he returned in poor general state and he was admitted to the hospital. He was discharged with rifabutin, ethambutol, and azithromycin, but unfortunately he stopped the treatment again. In this slide, we can see an illustrative image of the Mycobacterium colombiensis with smooth, creamy colonies with yellow pigment. So Mycobacterium colombiensis, it belongs to the Mycobacterium avium complex, MAC, a slow-growing type of Mycobacterium that infects both immunocompetent and immunocompromised humans. It was isolated for the first time in Bogota, Colombia, in 2006. It can grow after 3 weeks on media such as low-STI ginseng, Ogawa, Kudo and Sutton agars, but no McConkey agar grows. It can be identified from other species of the complex by the ability to produce urease. During a study to characterize MAC isolates in HIV-positive Colombian patients, a group of distinct strains were identified. These isolates showed several characteristics that allowed to differentiate them from other MAC members and were recognized as a new species. All 7 bacteria isolates were tested positive with the commercially available specific gene probe for MAC and were negative for Mycobacteria intracellular probe. 4 of the isolates also had negative results when tested with the Mycobacterium avium probe. This species has been identified as responsible for lymphadenopathy in immunocompetent children in Spain and France. It has been associated with lung infections that have complicated cystic fibrosis. And Mycobacterium colombiense infection in lymph nodes produce clinical and histopathological features suggestive of tuberculosis. Our patient was a patient with advanced AIDS, COPD, smoking, and alcoholism treatments. Mycobacterium cancei and Mycobacterium avium was detected in his sputum years before, and 6 years later, Mycobacterium colombiense was detected due to respiratory and consumptive syndrome during hospitalization. So in our opinion, this is the first isolate of this species in an HIV/AIDS patient in Brazil. There was other patient last year that a report was published in Pará State, but he wasn't HIV positive. These mycobacteria, being closely related, are very difficult to distinguish that, and there are the possibility that Mycobacterium colombiensis was the etiological agent early on. Due to unavailability of modern molecular tools to describe emerging MAC species, the true prevalence of Mycobacterium colombiensis in Brazil is probably underestimated. Thank you.
Okay, thank you very much, Marco. And now we have some time for questions for the audience. If you have some questions to Marco about this case or about Mycobacteria in general. I will have a question. Oh, sorry, Bradley. I didn't see you there.
Okay. Can you talk about treatment and what's the best treatment for this? And he was lost to follow-up, but do you know, did he come back? Did he get worse? Do you know?
O tratamento do Mycobacterium colombiense, como ele se trata de um componente,
Marcos,
de um integrante.
Just a moment. I will translate after that. Don't worry, okay?
Como se trata de um integrante do complexo Mycobacterium avium, se faz normalmente com rifampicina, etambutol, e pode ser usado algumas drogas venosas, como aminoglicosídeos também. Em relação ao nosso paciente, ele era um paciente que era, de certa forma, morador de rua. Então, ele tinha uma família, mas não morava, de certa forma, com a família, vivia na rua. Então, ele vinha ao hospital. Quando ele internava, ele ficava exigindo que ele tivesse alta. Ele não queria ficar internado. Assim que ele tinha uma pequena melhora, ele exigia, fazia, realmente criava muita confusão no hospital e a gente acabava tendo que dar alta. E ele era um paciente que tinha um estado mental normal, né? Ele foi avaliado pela psiquiatria, então a gente não tinha como deixá-lo internado. Então ele ficava nessas indas e vindas e a gente tentava manejá-lo ambulatorialmente, né? Todas essas culturas, essas sequências de culturas foram coletadas via ambulatorial. Mas o paciente, infelizmente, em 2016, foi a última consulta dele, no final do ano, e a gente não conseguiu depois contactá-lo. A gente ligava para a família, e a família realmente falava que não sabia, não dizia para a gente o que aconteceu com ele, infelizmente.
For how long? Quanto tempo, Marcos, só o tratamento?
O tratamento tem que ser 1 ano após a última cultura positiva.
Ok. So,
a última cultura negativa, né? Depois da última cultura negativa, mais 1 ano.
Okay.
Isso. No mínimo.
So the treatment is the normal treatment for this kind of bacteria is rifampicin and thembutol. Alternatively, they have AV treatment as aminoglycosides, but the treatment it takes it's a long treatment, and after the last negative culture, they have to treat for 1 year. After the last negative culture. So it's a long treatment, and for this patient that was homeless, it was really difficult to link him to this service and keep him in treatment. So possibly, this is a question that I was going to do. There isn't any question for the audience? Do you have any data on resistência, Marco?
Para a Mycobacterium colombiense não existe nenhuma padronização de resistência ainda, né? Porque foi isolado relativamente.
So it's a relatively young Mycobacterium, so they don't have still data on resistance, which is I think that's going to probably to happen as in tuberculosis, because it needs the patient to be very adherent to the treatment for a long, long time. So I think this is a huge problem probably for the future. So.
A grande questão assim que a gente levanta nesses casos é que o paciente ele tem uma baciloscopia positiva, aí a gente acaba já tratando como tuberculose, né? E devido à ausência, escassez de métodos moleculares, na maioria dos serviços no Brasil, a gente acaba não fazendo essa identificação dessas bactérias, né? De forma ou erroneamente como Mycobacteria atípica, né, sendo que existem mais de 150 espécies já caracterizadas.
So normally they treat for TB because they don't have how to establish the difference among the type of Mycobacteria, and sometimes they treat as a how do you say that, Marcos? As a typical Mycobacteria.
Not tuberculous, not tuberculous Mycobacteria.
Because they don't know exactly, so it's kind of an interesting work to work on resistance specifically, but you have to know which one you are treating. Yes. So this is tricky.
Yes.
Any more questions? I have one question, the last one. I think we still have time, which is the price for the diagnostic. You use culture in Fiocruz. This is what you use in the hospital where you work. Você usa cultura?
A gente usa a cultura, porque a identificação ela tem várias como que nós podemos falar? Várias etapas, né? Você vê a morfologia da colônia, o tempo de crescimento, e depois você faz alguns testes bioquímicos, né? Na verdade, o teste molecular ele é feito no centro de referência Hélio Fraga, né? Que aí lá assim eles têm todas as sondas, como é um local de referência no Brasil inteiro, a gente manda para lá e eles fazem a tipagem molecular.
É possível pelo serviço público?
É possível, é possível. Tem todo o fluxo estabelecido. As pessoas não pensam, né? Mas existe todo o fluxo.
So this is interesting because what Marcos is saying is that they have the culture, they have the time, they have a good lab, and if they need PCR, they can send it to some reference hospital, reference lab. And but normally the clinicians doesn't think about Mycobacterium, so they don't ask for the tests. And they have this test for free here in Brazil. So it is really interesting. Muito interessante, Marco. You have any questions? Okay.
Only a little question. But what about fungus, the diagnosis and the screening?
Lá nós realizamos todo o protocolo para fungos, né? Tanto as sorologias para histoplasma, capsulatum, aspergilos, e tanto no escarro, com detecção direta e cultura, quanto métodos sorológicos também, como galactomanana, a gente excluiu totalmente desse paciente, né?
So they use all the tests to exclude fungus infections in this patient, so it's really interesting. Okay? Okay, one more question.
Good morning. Are there reported incidents of Mycobacterium columbiense in non-HIV infected individuals?
Sorry, I didn't understand you.
Okay. Are there incidents of the Mycobacterium columbiense in non-HIV infected individuals? In patients with no HIV?
Okay.
Are there reported incidents?
Sim,
This
sim,
is what you
sim.
mentioned before, yeah.
Sim, há relatos de Mycobacterium columbiense, ele infecta tanto pacientes imunocompetentes quanto imunocomprometidos. Inclusive, o primeiro caso relatado no Brasil é um caso do Pará, né, do Instituto Evandro Chagas, que foi publicado, era uma Mycobacterium columbiense em um paciente de POC HIV negativo. Então, existem, na verdade, poucos relatos, se eu não me engano, existem 13 relatos no mundo inteiro, né, publicados. E um desses é desse paciente brasileiro HIV negativo.
So they have 13 stories about that in the world. One from Pará, Brazil, that was a man was not HIV positive, non-immunocompromised, but he was smoking. He has
heavy smoking
heavy smoker.
and COPD.
So 13 cases around the world. Okay. Any more questions? So we'll follow up the session. Please, Freddy.
Okay, thank you,
Thank
Dr.
you.
David. The next presenter is Dr. Natasha Tsekova Traykovich. She will present the case Penile verrucous squamous cell carcinoma in a patient with non-Hodgkin. She is from University Hospital Alexandrovsky, Sofia, Bulgaria, Department of Dermatovenerology. Doctor.
Good morning, everybody. I'm going to present you a case of penile verrucous squamous cell carcinoma in a patient with non-Hodgkin lymphoma. Our patient is 60-year-old, heterosexual, uncircumcised male, immunosuppressed due to the treatment of non-Hodgkin lymphoma with cyclophosphamide, adriamycin, vincristine, and prednisolone for 2 years. He had a history of promiscuity in the past, and he is a long-time smoker. He smokes 50 cigarettes per day. He reported about the multiple condyomata acuminata on the penis with a long lapse on the place where the tumor is, and the treatment with different topical modalities was with unsatisfactory effect. This is the clinical presentation of the tumor. You can see the erythematous exophytic papillomatous 6 centimeters plaque on glans penis with no well-defined borders. The lesions is within 4 months duration. There is some places with the gray whitish color with depression, probably as a result of the local destructive therapy. The lesion is soft, without hardening underlying tissue in the affected area, and food odor is observed. Lymphadenopathy was not apparent. For the blood count, liver and kidney test was with normal rates, and serology was non-reactive. From PCR for HPV DNA, we isolated types 6, 11, and 16. This is the histology examination of the patient. You can see the well-defined squamous cell carcinoma with hyperkeratosis, parakeratosis, acanthosis with bulbs projection into the dermis, and there is no fibrovascular cord in the examination. We send 1 month later, we send the patient to the urology department, and the excision and amputatio penis partialis was performed. Histological examination of removed material was again reviewed, and was established like verrucous carcinoma with invasion in the subepithelial derma with depth of the tumor invasion 2.1 millimeter and desmoplastic stromal reaction. There was no invasion in the corpora cavernosa and corpus spongiosum. Penile verrucous carcinoma was first time described in 1948 by Ackermann and has been reported in the oral cavity, and after that a lot of cases was described with different localization. It's extremely rare, well differentiated and low-grade tumor that exhibits slow invasive growth. It's a rare tumor. It's 2.4 to 24% of all penile cancer. In the past literature, the diagnosis of verrucous carcinoma has been very confused with giant condylomas and papillary and verticarcinomas due to the absence of critical criteria in pathological diagnosis. In the WHO classification, World Health Organization classification, each verruciform lesions is clearly defined within histological criteria, and verrucous carcinoma is a distinct pathological entity separate from the other verruciform lesions. The morbidity associated with the penile carcinoma is correlated with the poor education, a low income, a history of heavy smoking, chronic inflammation, HPV infection, frequently phimosis, and poor genital hygiene. The tumor is often presents as cauliflower or wart-like and do not cause significant pain. It slows growth without inhibition, and regions of the carcinoma can invade the glands or even the shaft. Unpleasant odor and results in pain is due to necrosis and infection of the tumor. Inguinal lymph node and distant metastases are observed very rare. The diagnosis is based on clinical presentation, histological examination, and PCR for HPV DNA. But the diagnosis is based on histological examination, where the tumor shows papille with acanthosis without fibrovascular course, and the tumor bus is regal, bored, and pushing. Colocytic changes are not always evident, which means that verrucous carcinoma is considered not to be always HPV related. The treatment of the tumor depends on the grade of the tumor, but the surgical excision, partial or total penectomy, is the treatment of choice. And don't forget the prophylaxis with the available vaccines nowadays. And thank you for your attention. This was all.
Thank you very much, Natasha. And I with the pictures, I am now waiting to go to Bulgaria. You have very nice pictures of your country. So, any questions for Natasha, please? Again, Bradley, let's go.
I'm very happy that you've taken the time to present this. What is the difference between verrucous and condylomatous carcinoma? They seem very similar to me.
Yes, it's a histological. It depends on the histological picture. In verrucous carcinoma, we can't see the fibrovascular cords. And in condylomatous carcinoma, it's always HPV related, and there is a fibrovascular cord in the on the histological examination. That's the main difference. But in the literature, it's a little bit a mess with the terminology of these tumors, because some authors means that the Buschke-Lowenstein tumor and verrucous carcinoma is the same. Some authors think that the Buschke-Lowenstein tumor is something between condylomata acuminata, and then you have a Buschke-Lowenstein tumor, and then the verrucous carcinoma at the end. It's the classification. No. Just the histology is the only one which can define it. And also the HPV, because the verrucous carcinoma, the most of the cases are are not HPV related. They are HPV related in different studies between 10 to 20%.
And this about the HPV related thing. No, we know that most of the penile cancers are related with HPV now, but how do exactly which is the cause? Because if you mention the cause that you said, okay, poor hygiene, non-circumcision, everything, it looks like all the other penile cancers. But
Yes,
I would like you to discuss more the causes on the.
Yes, on the microscopic clinical picture, almost all the penile cancer, which are verruciform, looks in the same way. But histology is only one which can define it.
Okay.
And also we can do immunohistochemistry, for example, to exclude the HPV oncogenic
The presence
types.
of
Yes.
the HPV. And the non-oncogenic types, you can see that they have, you can see some reports of tumors caused by non-oncogenic types of HIV, HPV in HIV positive patients.
In HIV positive patients,
Yeah.
I'm sure that the tumor is more frequently than the others, like the other tumors.
Okay.
For Kaposi sarcoma, for example, but penile cancers are very rare, like a pathology. So there is, in literature, I can't find the review about the percents and the other things about.
So lots of field to research.
Yes.
Okay. Any more questions? I think it's a very interesting thing. Yeah. You have the chance to learn about that. So, okay. Thank you very much, Natasha. Thank you.
Yeah, maybe we will finish early. Thank you very much for your attention, and thank you, Natasha and Dr. Davi.